the unique considerations, barriers, precautions associated with each respective to the scope. We just want to examine and review best evidence for mid-stage treatment. So again, we've classified these stages of rehab according to research and again our own experience, so that 8 weeks to 16 weeks. And then improve everyone's ability to appropriately load, most importantly, organize a treatment session and address individual deficits when returning to sport or preparing for return to sport. We're going to review some best case evidence for return to sport run testing, return to sport testing, and strength measurement for ACL. And very importantly, we're going to discuss the importance of transitioning to a strength conditioning professional after successful completion. Orthopedic example, ACL. One of the most common sports injuries, right? All of us have, it's like the most popular sports injury out there. So surgical considerations, right? We have two different types of graft that are more commonly done, autograft and allograft. We have the VTB versus quad versus hamstring autograft. There could be a meniscus injury, a lot of other options that come along with the surgery, right? Some postoperative complications could be infection, range of motion deficits, cyclops lesion, pain, swelling, patellar fractures, which are rare. So we have the stages of healing. We talked about the early stage, mid stage, and late stage. They were sort of kind of grafted off of this idea of the 3 stages of tissue healing. So using NSAIDs in the beginning to control inflammation, we're going to start to get the point of weakest portion of the graft. And then in the mid stage, right, we're going to start to proliferate. We're actually going to see some graft growth and hardening, which is why we want to kind of load them according to strength conditioning principles, make sure we're properly dosing that ligament to get the strength. Otherwise, without it getting resistance, it's just going to stay the same, right? It can get stronger and more resilient, but truthfully, without loading, it's not going to get any better. And then lastly, maturation ligamentization. So we're going to start to see production of type 3 collagen. This is where we start to see the hardest and the most robustness of the ACL. Tissue healing biology ranges early stage anywhere from 3 months to 6, kind of as we talked about, 6 to 9, and 9 to 12 for maturation, or 12 and beyond.
So when I was in school learning about ACL reconstructions, we were kind of in the graft is at its weakest at 8 to 10 weeks. Research has progressed a little bit since then. We actually find that it gets a little bit weaker and dips down below the strength of the native ACL around 3 months, then goes through the ligamentization phase, and then starts to surpass the strength of the native ACL. Looks like around 6 to 9 months, and then progressing from there. So the way that I can kind of conceptualize this for myself is thinking about it like buying a new car. Buying a new car, as soon as you drive it off the lot, value starts to depreciate. Put the ACL graft in, as soon as they walk out of the operating room or get wheeled out of the operating room, that graft strength starts to decrease. And eventually, over time, you get to the point where you take good care of it, you apply load appropriately, you change the oil, you keep air in the tires, et cetera, and then it becomes vintage, and then it's worth more again. So that's kind of that dip there from the ligamentization phase back into that 9 to 12 months where that graft becomes strong, and then again stronger than the native ACL, and potentially stronger than the contralateral ACL. So we're defining mid-stage, again, like Rich said, kind of based on some of the research on the RTSCC, just kind of some of all of these overlapping principles. We're at about 6 weeks and then moving forward from there. 6 to 14, 6 to 16, again, this is all very fluid. It depends on the patient, it depends on a lot of things. But this is about the time in the mid-stage that we're starting to get away from really protecting it and starting to really push it, starting to give it some load, starting to get to the point where it looks a little bit more like training, a little bit more like exercise. It sounds early, but really you'll see that people start feeling really good around 4 to 5 weeks, and they're already itching to do stuff. So if we're waiting another 3 weeks to kind of kick all this stuff off, they're already chomping at the bit to do so. So it's right in the safe stage of the healing phase and of the kind of tissue irritability. So this is just kind of a little graphic, so you can see that in the beginning it's a lot of rehab, and then somewhere in the middle it's a pretty even mix of both, and then towards the end it's only a little bit of rehab. There is some evidence that there's quad weakness that lasts up to 2 years after surgery, so even when they're that far out, there is going to be a little bit of rehab mixed in with your training, whether it's some isolated quad stuff, whether it's tending to some knee extension lag, a little bit of range of motion deficit, crankiness, soreness. There's going to be a little bit of rehab still lasting into 2 years post-op. In the mid-stage, throughout the recovery period. But in the mid stage, there are a lot of things to consider because we are transitioning from that protective to more of that training phase. But this is about the point where we want to start increasing intensity overall, so increasing session intensity, increasing exercise intensity. So some things that we need to start considering here are things like the graft type. So now, if they had an autograft specifically, you want to consider the donor site as you're starting to load. So you can consider if it's a patellar or a hamstring autograft, you can start thinking about that like a tendinopathy. How are we going to load a tendinopathy? How are we going to protect it? It's going to be sensitive to stretch. It's going to be sensitive to high velocity. So we're going to do isometrics, low loading, but make sure that we tend to those tissues. Make sure that they don't hold us back from some of our other progress. A really big consideration is going to be age. We see patients from, I don't know, what's your youngest ACL, 11?
Yeah.
I've seen an ACL in their 50s, so like you have that big age gap. So there's a lot of things to think about. When you have an 11-year-old, you got to think about how well are they going to be able to pay attention and follow the protocol? How well are they going to keep their precautions? How much education are you giving the parents? How hard are the parents on them? What does it mean to them to play a sport? What does it mean to them to be a kid? Now with kids, you're going to have a lot more recreational activity. They're going to want to ride their bikes with their friends. They're going to want to go out and play tag. They're going to jump off a swing set. They're going to do all sorts of dumb stuff because they're kids and they don't understand, right? So sometimes making sure that we're getting them back to being kids is a lot more important than making sure we get them back to their sport. Another consideration for a child athlete is this really big trend towards early specialization. So am I treating a kid to go back to being a soccer player because they play soccer 12 months a year? Well, maybe they don't have the athletic base that they need. Maybe their upper body strength is lacking. Maybe their general strength in their lower extremities are lacking because the only thing they do is play soccer. So now we're going to think less about getting them back to soccer and more about building an athlete, so that as they continue to progress through their athletic career, they're less likely for another ACL injury, the contralateral side, or any other type of injury. On the flip side of that age discussion is now we'll talk about our 50-year-old. They have an active job and they're out of work. So now they're going to go back to work probably faster than we want them to because they didn't get hurt at work. They got hurt playing basketball or something dumb with their friends, but they haven't played basketball in 20 years and thought they could try to dunk, and they tore their ACL. So now they aren't working, and now they're trying to figure out how they can get back to their job as an electrician or a plumber or some other work where they need their knee. And they're going to push the protocol, and you're going to have to really meet them where they're at and try to get them back to that as soon as you can. And it's not going to be to get them back on the basketball court. It's going to be to get them to be able to go back to work so that they can provide for their family, so that they can coach their kids' baseball team, whatever it is. So those are a lot of considerations outside of just an athlete. Like when we have someone that is active in any way, that makes them an athlete. Just a different, again, we're varying by degree, not kind. They're just a different kind of athlete. Training history starts to come in, again, with a kid. How good is their movement literacy? Can they squat with, good, decent technique? Have they ever squatted before? Have they ever touched a weight before? Do they understand what it's like to lift weights? Same thing now with adults. How active are they as far as exercise? How healthy are they? Do they like to spin? And you have to convince them that it's time to start strengthening their quads. Do they only want to, power lift, and they haven't, gotten their heart rate above 115 in 30 years? Like, there are all these different considerations to tailor this program and to tailor this rehab to get them back to where they want to be, which is great. It's fun for us. It gives us so much latitude. There are so many different options and so many different ways to get these people back to where they were pre-injury and where they want to get to. Current training centers, individual goals, yeah, same kind of thing. So the consideration here is making sure, now we're going to go back to the athletes a little bit. Maybe we have a high school athlete or a college athlete. What was their training volume pre-injury? We have to look at their weekly strength training, their weekly aerobic training, how many practices, how many games, how many hours per week are they being athletic? Because we have to build them back up to that at some point. So if we are, seeing them for 45 minutes twice a week, and their heart rate again hasn't gotten up above 115 in 16 weeks, now all of a sudden we try to put them through their return to run, return to sport testing. They go to their closed practice environment, and they're just completely unprepared. And then they have to spend another few months getting their aerobic capacity back, and it just sets them behind in their timeline overall. So some of our goals in the mid stage is basically, the ultimate goal is to prepare them for late stage. So we want to get them through a return to run test so that they can start running. And then we want to get them into a good program that will cover the end of rehab, which tends to be around 16 weeks, and then their first shot at a return to sport test, which is around 6 months. So how are we preparing them to bridge that gap so that they can have the highest chance of passing their return to sport testing so that they can be cleared to enter into that continuum? So the first thing we want to kind of focus on is the thing we can focus on the earliest is developing and maintaining an athletic base, and that's just a lot of aerobic capacity kinds of things. So in the case of an ACLR, we can go ahead and use a ski erg, we can use RUBEs, we can use, to some degree, we can start using a bike. Potentially we could use a rower depending on their tolerance to deep knee flexion. We can just start giving them some intervals and stuff like that. When we're looking at aerobic capacity, we're probably going to prescribe these sorts of things outside of the clinic because of the high time demand. You're not going to get a whole lot of cardio benefit with something under like 20 minutes, so we can't spend 20 minutes of our session obviously watching them row. So what a great way for us to get some anaerobic conditioning is to prescribe some intervals. They can be at a higher intensity, do work rest periods, and get some good work done in shorter periods of time. And then you can kind of look at their, you can watch their technique and kind of give them some guidance as far as how they're going to progress with that. Same thing as far as generalized strengthening. Maybe you are going to either prescribe or recommend consultation with a strength and conditioning coach or a personal trainer where they're going to get their contralateral limb and then their upper body for all that kind of strength training in. Again, because we just don't have time to do that in the clinic. So that's like kind of a real life consideration there is we really need to focus on that leg. We got a lot of things to focus on. So getting some of that stuff pushed out to outside of the clinic. So then we're looking at obviously getting quad strength. Quad strength is king in ACL reconstructions. All the research points to quad deficits being a really big indicator in a re-injury on the ipsilateral side. Introducing plyometrics. We talked a lot about extensive and intensive plyometrics. So an extensive plyometric is one that you can do at low intensity over time. So you can think about something like jumping rope versus an intensive plyometric, which would be a max effort. Again, that would be like a box jump or drop jump, bounding, those sorts of things that require a lot of effort and kind of nervous system output. And then under this consideration of extensive plyometrics, if you think about returning to run and jogging, it seems like jogging is just a thing that we should be able to start doing, but jogging really is just a series of extensive plyometrics. It's just single leg landing over and over and over again. So sure, they pass all their tests for return to run, but how have we prepared their tissues for return to run? Have we been doing extensive plyometrics? So we've been making sure that they can do some single limb loading, single limb landing. What else are we doing to get them ready to actually do the task of jogging instead of just being like, oh, you passed your return to run test and now start jogging? In order to be able to run and change direction and do all sorts of other sports things, we need to be able to stop. So in order to stop, we have to decelerate. So that is a really big consideration in your plyometric prescription when you're in this phase of rehab, starting with double leg, progressing to single leg, etc. Deceleration is a very big component in returning to sport. So we talked a little bit here about how to structure a program. So kind of just generalize things into 5 categories. So the first, we're looking at plyometrics and power. So we talked a little bit about extensive and intensive plyometrics. You're going to throw your deceleration sorts of drills into here. And then also power. These are going to be your power movements as well. So sometimes before they're ready for plyometrics, you can start using power movements for strength training. And that just means that there's a time component. Power just means work performed over a period of time. So whether you're cueing for move this as fast as possible, do this as fast as possible, this is where you're going to start to get a little bit of that kind of stretch and contract cycle going on. And get those tissues ready to absorb forces, produce forces, change contracture type rapidly. So you want to do these in the beginning of your session because it is high effort, high motor demand. So you'll get a lot of central nervous system fatigue with these. So not ideal to do these under fatigued conditions when they are kind of the meat of your program. Is when you're really focusing on these things. You want to try to keep them in the beginning of your session. After that, Again, now we want to start moving to our main lift. So we're thinking about our big compound lifts. These also require a lot of effort. They require a lot of muscle and motor recruitment. So again, closer to the beginning of your session, limiting fatigue before you start. So just a very simple way to kind of program these is pick 2 to 4 exercises. Again, it depends on where you're at in your rehab. If you're a little bit later in your rehab, maybe you're picking 4 exercises. If you're a little bit earlier, maybe you're picking 2. Considerations there being muscle isolation versus compound muscles. So 2 to 4 exercises, 3 to 4 sets of each. For these strength, you're looking in like the 1 to 5 rep range. Don't do a ton of singles with people unless they are powerlifters and all they ever have to do is a single. But we're looking at like a little bit of a lower rep range with a little bit of a longer rest. So rest is important here because we want the muscles to fully recover between efforts. We have talked about RPE a bit, so we'll review that. That's rate of perceived exertion. I like to use RPE, reps in reserve, is another way that you can measure intensity, but it's a little bit harder to explain. I've been going with like hey, was that easy, medium, or hard? If they say it was medium, I said, well, was it hard medium or easy medium? So I'm just trying to get a feeling of how challenging they felt like that exercise was, so that I make sure that I'm hitting the appropriate intensity and stimulus to produce some muscle, produce muscle growth. Sometimes they can't describe it to you, right? So they will move something with a really rapid tempo, and then they'll tell you that it was really hard. If you watch them and you know that it wasn't. So sometimes you just need to use the eye test. They're not like grimacing or making a face, or the speed of contraction hasn't slowed down at all. It's probably a little bit underloaded there. So maybe consider for the next session either increasing the dosage somehow. And that's where you can play with your tempos, you can play with your loads, you can play with your volumes, you can play with your range of motion, other external constraints to make that exercise a little bit more challenging. From there, the next kind of grouping of types of exercise is muscle endurance. So that's going to be your more accessory movements. You can think again more of like your single joint exercises. So these are going to be programmed just a little bit differently. As far as volumes, you're going to go for higher rep ranges here. 8 really is kind of the 8 to 10 is kind of the threshold for endurance, and can go all the way up to 30. For some of your more longer acting muscles, I like to do higher reps, like in the 25s and 30s for when I'm doing gastroc strengthening, because they're active a lot, so they need to have a lot of muscle endurance. Again, 2 to 4 exercises. So now if you're earlier in your rehab, you're spending more isolated quad time, you're spending more isolated hamstring time, so you're doing more of these exercises. So 2 to 4 exercises, 3 to 4 sets. Like I said, 8 to 30 reps, which is a huge range. And then the rest is a little bit longer, it's under 90 seconds. So now we're not letting the muscles recover quite as well in between sets. And you want these RPs to be down around 5. So their first rep should feel like a 5 or a 6, and then maybe by the end of that set, it's about a 7 or an 8, but it starts really feeling pretty light. Now as we get that volume up, you want to start thinking about DOMs. So how eccentric heavy was that? Were your exercises for that day? Do I want to see them in 48 hours, or do I want to push it out to 72? Anywhere between 48 and 72 for a high muscle endurance session is kind of ideal to give them time to clear that soreness and really be ready to start at the next session. Again, we live in a world where we can't always do that. Schedules and their schedules and our schedules and all that. So in that case, maybe they come in and they're super sore from their last visit. Just maybe move and train some other body parts a little bit harder. So if their quads are super sore, maybe you're just focusing a little bit more on glutes and hamstrings and kind of posterior chain. Maybe you're going a little bit more into some of the lighter, extensive plyometrics versus doing some of the heavier strength training that day. This is a really good place to start introducing some of the sport-specific types of the exercises. So using your accessory period here to pick exercises that either mimic their sport or at least really focus on the muscles required for their sport, and introducing some multiplanar movements here if they're a rotational type of athlete. Just making sure that they're getting the muscles that they need are getting hit. And we're not just building a strong person, but we're building a strong person to do the athlete, or to do the sport that they're trying to get back to. Towards the end, we can look at doing some neuromuscular and some balance types of exercises. These typically have to be done at a higher volume because motor learning takes a lot of repetition, and we could go down a rabbit hole of block practice and other practice schedules, but it's largely going to be clinician preference, patient preference, time constraints, time demands, et cetera, et cetera. So it's just good place is kind of put that in towards the end, and it's really good to start training some of that neuromuscular stuff under fatigue, because that is going to be the nitty gritty when they get back into their sport and they're participating in competition. And then lastly, ending with a cool down or some mobility. This is a great time to work on any range of motion deficits that are still persisting. Like I said, we're in the mid-stage rehab here. Their range of motion should be within 10% or so of their other side, but maybe they still have some deficits or some irritation. Do a little bit of mobility here, get a little debrief of the session. How did that feel? How hard was that overall? What exercises did you like? What exercises did you hate? What can we tweak for next time? Where did you feel comfortable? Where did you feel uncomfortable? Those sorts of things. And then some patient preferred recovery. In this this kind of cool down period, I would kind of be remiss not to mention some of the research surrounding use of ice as a recovery method after strength training. There is some mechanistic data that suggests that it impairs muscle regeneration. So when we're in a phase of trying to build muscle, applying ice to the muscle after the strength training session might be counterproductive. But we live in an evolving world and ever-changing and patient-specific, so we have to take into account surgical guidelines, surgeon preference, patient expectations. But might not always be the best thing to just slap ice on it at the end if we're really looking to gain some quad strength and quad hypertrophy. So if we look at each session that we have with the patient as a bucket, the bucket can only hold so many things. The bucket is based on time, the patient's probably attention, especially if they're 11, their tissue tolerance, and their readiness to train. So you can take a little bit from each of these sessions, each of these pieces, and throw it into the bucket. And every session might be a little different. Like I said, if they're coming in a little bit sore, maybe we're maybe we're dedicating a lot more time to our cool down and mobility than we did in the previous session. Or if they're really ready to hammer it and get after it, then maybe we're adding, we're spending a little bit more time in that strength and we're doing 4 big main lifts instead of only 2. Or maybe they're a marathon runner or a volleyball player, or someone that needs to jump a lot, and we need to do 20 or 30 minutes of plyos. So it's all just different, playing with those variables. Again, leaves us so much latitude as far as how we structure our sessions, how we interact with our patients, now we progress them through the rehab. These are all just things to consider when you're building a really well-rounded, comprehensive program in this stage of rehab. While I said that getting that main lift in the beginning, getting those plyos and that power in the beginning is ideal, we don't treat an ideal. So if they need to get their squats in, and you can't do it till the end of the session, then it's done is better than perfect.